This kind words and very nice introduction, and of course I really feel thankful to Our Lady of Diabetes, Professor Ines Jaltout, because who is a very dear friend. Also, I owe her a lot, and we are very proud of her being the Lady of Diabetes in Egypt, and more success for this honorable meeting, and maybe we will the 18th, and we will enjoy the 20th, and the more success for Professor Ines Jaltout. My presentation today about obesity and the cardiovascular disease, and of course, as we know, obesity and the cardiovascular disease, obesity of course is a disease by itself, and it's an association or a cause or an effect relationship. What does that mean? Now we're talking in cardiology about the obesity cardiomyopathy. So it's a real very important, it had an impact on cardiovascular disease, and the mainstream findings suggest the presence of cardiac hypertrophy, again decreased vascular compliance and ventricular pump function in obese individuals, independent of obesity-related vascular disease. So now we are talking about the obesity cardiomyopathy, and this is a really very important item. Very interesting, it was seen that what are the types of fat, as we all know. It depends on the location of the fat. We have the white fat, of course, this is the subcutaneous tissue. We have the brown fat, the visceral tissue, and very importantly to say the inhomogeneous, this is the perivascular fat. It's epicardial, it is pericardial, and it's perirenal. This is really very important and amazing. What is the perivascular fat? Actually, this is a very important, and we are talking now in cardiology about this important item, and it's virtually all blood vessels are surrounded by adipose tissue. Also, the heart and kidneys are surrounded by fat. The perivascular fat is inhomogeneous and differ from the subcutaneous and visceral fat with regard to the messenger RNA, and it encroaches directly on the adventitia without visceral layer, and thus humoral factors secreted by the perivascular fat have an easy access to the blood vessel and can function as paracrine organ, transducing directly to the vascular cells. We have to stop about this very important fact, because this has a really direct effect on the heart, and the mass of the perivascular fat correlates negatively with insulin sensitivity and increase, of course, the production of atherogenic factors. This is very important. What about obesity? Obesity and the cardiovascular morbidities, this is my agenda, the obesity and hypertension, the dyslipidemias, obesity and heart failure. Comorbidities with obesity, of course, as we all know, that definitely whenever the person is becoming obese, actually will have more comorbidities. It definitely, unfortunately, Egypt is one of the fattest countries in Africa, as well as in the top in the whole world, and definitely it has a perfect, it's a relation with all-cause mortality. Among them is the cardiovascular disease, as we all know. What about life expectancy? Life expectancy decreases whenever the body mass index increases. And we do have in the cardiology studies, clinical studies. One of these studies is the Framingham study, and this had a long follow-up for patients with heart disease, and it was found that when you are obese at the age of 40, probably you have less 7 years, your life expectancy will be less than 7 years than expected for your age. Definitely you do have the life expectancy decreases as the body mass index increases. When we are talking of cardiovascular disease, we know that a continent each year disappears due to heart disease. We do have around 100 million, 18 million in the whole world dying from coronary heart disease, and Egypt, 46% of Egyptians die from heart disease. And of course, cardiovascular disease is the primary cause of mortality in the obese, as we all know. What about hypertension? In Egypt, in the 100 million initiative, it was seen that the presidential initiative of 100 million initiative, it was seen that around 30% of Egyptians having high blood pressure, that is hypertension. So as we all know that we have, this is the normal blood pressure, and the target levels of the patient, definitely it's a little bit lower in diabetics and in those having chronic kidney disease. Again, those having body mass index more than 25 are 3 times more likely to develop hypertension than healthy subjects. Again, and when we are talking about hypertension, we are talking about an array of different diseases, and so many of them will have a lot of diseases alongside with hypertension. The prevalence increasing, definitely it increases with the high body mass index. And in the cardiology, we have our dear Professor Mohsen Ibrahim. He is the head of the Egyptian Society of Hypertension, and he had a very important project years ago. Probably it was very evident that in these patients in Egypt, we do have, whenever you become more obese, you will have more hypertension. Of course, and obesity-related hypertension is a multifactorial and the polygenic trait. And of course, I enjoyed very much that presentation about the personalized type of medicine, and so we do have to talk about that. Hypertension management. We have primary agents in the form of diuretics, thiazide, ACE inhibitor, ARBs, calcium channel blockers, and we have secondary agents like loop diuretics, potassium spilling diuretics, and actually we use in a combination therapy. It's very rare in dealing with a hypertensive patient to start with one drug. Maybe you have to have combination therapy. What about obesity-induced hypertension? Will that be different? Really, it's actually, you do have to stick to lifestyle modification. Usually, you need to have more than one drug to start with. Maybe the patient may need bariatric surgery, and this is, of course, an important line for treating obese hypertensives. So definitely we have challenges in all, and even minimal weight loss improves high blood pressure. So when you are dealing with obesity, you're definitely dealing with all cardiovascular risk factors. One of them, the hypertension, as we all know. Weight loss reduces blood pressure, especially for the systolic blood pressure, which is really very important, and bariatric surgery reduces around 52% reduction in blood pressure. What about dyslipidemia? We had a very important clinical study follow-up for patients, and we found that around 36% of Egyptians having dyslipidemia, and this is a really very threatful situation for cardiovascular disease. And what about dyslipidemias and dealing with obesity? Definitely there is a great relationship, but it's a common link between obesity, metabolic syndrome, and of course diabetes. The link will be the metabolic syndrome. Actually, we had a clinical study about Egyptians having the metabolic syndrome, and we found that around 20% of the Egyptians are having the metabolic syndrome, which includes, of course, obesity and dyslipidemias and other risk factors. These times in cardiovascular medicine, we are dealing with very low levels of lipid profile. And in the last guidelines coming from the European Society of Cardiology, we didn't imagine in one day that we have to go low as to an LDL of 55 milligram per DL, and 45 even to 40 in many patients. So now we are facing an important guidelines coming down and down with the needed target for the blood lipids. Dyslipidemia is, of course, having a long risk factors, and one of them, dysglycemia, obesity, smoking, race, ethnicity, and so and so. However, is it different from dyslipidemia coming from the obese, from the non-obese? Of course, it's different, and we have probably these patients, we do have triglycerides with a little bit high, and this is a big issue, and is by itself is a risk factor for ischemic heart disease. The treatment decision, now we are talking about very low levels to have treatment decision, and now we are talking about LDL of 55 as low as we know. We do have risk scores in cardiovascular medicine, and now we are dealing with the cardiovascular risk by different scoring systems, and by this, so you are just tailoring the treatment according to each patient and according to the risk of the patient. Of course, definitely the weight loss has a favorable effect on dyslipidemia, which is really very important. And it, again, improves the clinical features and long-term metabolic health in patients with dyslipidemias with a very important effect. LDL. Now in cardiology, we're not talking a lot about cholesterol, but we're rather talking about LDL. And actually, this is the key factor in determining the side effects or the clinical complications in heart disease in the heart, and maybe it has a direct effect on weight loss on the LDL. With an improvement in the whole lipid profile, in the cardioprotective HDL as well, it may have an important effect. Lowered cholesterol, on the other hand, the other side of the coin, decreases the risk of heart disease and stroke, and this is really very important, and heart failure. Nowadays, of course, in cardiology, we are talking about heart failure. We do have new drugs for heart failure. We are talking about 4 main pillars of treatment of heart failure, and maybe one of them, the first step in this, is to have a lifestyle medicine. And now we are talking about lifestyle and lifestyle medicine as one of the main treatment or mainstay for treatment of heart failure patients. We're talking about those, as you all know, that heart failure patients is around 50% of them die within few years of their life, and it's really we have 2 types of, as we all know, it depends upon the echocardiography. If you have a normal ejection fraction, you have this is preserved ejection fraction, and as this patient, you do have all signs and symptoms of heart failure. All of them, risk factors predicting the preserved ejection fraction patients is one of them. Very important. Diabetes, of course, obesity as well plays an important role. Definitely, again, as hypertension, as dyslipidemia, again the heart failure. Heart failure really is the mainstay of all heart disease, and again with the obese, we all know that it is really the risk, the incidence over time increases with the body mass index. Also may contribute to the development of preserved heart failure. So obesity per se, due to having a cardiomyopathy per se, it leads to heart failure, and we don't have treatment, but lifestyle is the mainstay in this type of patients. The approaches for patients with preserved heart ejection fraction is that they have the stigmata of heart failure, but they actually have a preserved systolic function. This is by the echocardiography, and we do have now advanced techniques for a diagnosis of heart failure with echocardiography, and we can prevent, yes, we can prevent by adopting a lifestyle, by having sustained weight loss, and this, of course, will improve. In cardiology, actually, we are just having a big debate about the heart failure with preserved ejection fraction, but actually, we do agree that when you improve the risk factors, everything will be fine and marked improvement will be there. Major cardiovascular, adverse cardiovascular events, as we all know, it will be all much improved, and weight loss responders have improved the cardiovascular outcomes regarding the cardiovascular death, the non-fatal MI becoming less than 21%, and the secondary outcome becomes 24%, and actually definitely there is a good relation by responding to decreasing the heart, the body mass index and waist circumference in this type of patients. With some of the drugs given in its April, the GLP analogs maybe have multifactorial effects that may benefit several disease states, along with having a favorable effect upon the diabetes as per se. It has an important role and impact on the chronic weight management, which is really very important, and this is really and it has in the LEADER study, and it studied the liraglutide for those patients having definite cardiovascular risk, and in comparison with placebo, actually it wasn't placebo, and this type of patients, actually it was shown that they had the standard treatment for the condition or for that high risk cardiac condition, and it had a favorable effect that it offered safety to the heart, and it decreased the cardiovascular risk, it decreased the non-fatal MI, it decreased the non-fatal stroke by a quite considerable, around 13%. In the population. This is really very alarming. So my conclusion today is that obesity is the most important modifiable risk factor, and it's even more important than smoking and the progression of cardiovascular disease. Moderate weight reduction can result in a major cardiovascular benefits. Fit obese is better than sedentary obese. This is an important, and this is highlighting the importance of exercise. I have very good news, that to say that we can prevent 80% of cardiovascular disease, which causes millions of Egyptian pounds on for the Egyptian people, and so this is fortunately you can, by self-care, prevent 80% of the incidence of heart disease, and you can avoid professional care by 20%, whether it's primary, whether it's secondary, whether it's tertiary. So we have the art should have adopt the preventive strategy and take it our base, and this will have a favorable effect. I have just to say that waist circumference now is becoming a new vital sign. So we have to look for the obesity as one of the important risk factor for heart disease. This is my last slide, and I think this is the most important slide. And this important equation, and it was brought from the European Society of Cardiology, and denoting how preventive strategy will have a favorable impact on your whole lifestyle, on your quality of life. By adopting this equation 035140530, this is as if it is a telephone number from Alexandria. As you can see, you say, to have people who stay healthy tend to have certain characteristics. 0 stands for tobacco cessation, walk 3 kilometers a day, or 30 minutes, any moderate activity. Definitely exercise is the cheapest drug you can be to prevent 20 chronic diseases. And take 5 portions of fruits and vegetables a day. Blood pressure you should keep below